Thank you very much for coming. My name is Joan Batorf. I'm a professor in nursing at UBC Okanagan, and I'm director of the Institute for Healthy Living and Chronic Disease Prevention on campus as well. And we're delighted to be hosting this event tonight as part of UBC's Celebrate Research Week, as well as part of our Embrace Aging Month. So during the month of March, we're offering a host of events on healthy aging and just other issues related to aging as well. If you didn't pick up a program for the 20-some events that are happening in March, please do so. We're co-hosting Embrace Aging with Interior Health and also Interior Savings, who are very helpful in helping us host these events. So tonight the topic is sidestepping the effects of stroke. And it's wonderful to see so many people here because there's so many interesting things happening in this field. And I know you're going to hear about some of them tonight. So I want to tell you about our format first, just to give you an idea of what the evening will be. We do have a few chairs back here. Come on in. We have brought together a panel tonight of 5 experts, and we're going to ask each one of them to talk for 10 minutes. There's some note paper on your table, so I would encourage you to take notes or write down your questions, because after each person has had a chance to speak, we're going to take a short break for 10 or 15, actually for 15 minutes. We're going to have refreshments there. So you'll have a chance to think of other questions or comments that you might want to make. And then we're going to reconvene and we're going to have a discussion. So it's a time where you can ask questions of our panel, any one of our panel, and quite often more than one member of our panel might provide information in relation to a question, and or to offer any comments that you might have. So, and we will, at the end of that discussion period, we'll ask each one of our panelists to give a closing remark, a take-home message, perhaps invite them to say something that they didn't have a chance to say. It'll just be a brief comment, and we'll close the cafe at 7 p.m. So there also are some evaluation forms on your table, and before you leave, I would encourage you to fill those out because they'll really help us plan this event for next year. This is probably the 8th or 10th cafe that we've held here in Kelowna, and we're very interested in continuing to host these. So also, just to let you know, we may be taking a few pictures tonight of our event. And if you don't want to be, you might just be included in a picture. I can't guarantee that, but if you don't want to be included in a picture at all, if you would let either myself know or Jaquetta, the person who was probably directing you upstairs, she'll be back up here soon, do just let us know before you leave. So without further ado then, I'm going to introduce our panelists. So our first panelist is Ms. Jennifer Monaghan, who is a stroke survivor. Jennifer Monaghan is a full-time mother and former lawyer and survived a major stroke 5 years ago. But luckily, her husband recognized the signs of stroke and got her to the hospital where she received TPA, the clot-busting drug. After a month in the hospital, she was discharged, only to feel completely lost and unable to find any resources to continue her recovery. She decided to fix this, and she started volunteering for the Heart and Stroke Foundation, Living with Stroke, the BC Stroke Collaborative, and Interior Health's Stroke 101 classes, and speech therapy groups, all in an effort to help stroke survivors like herself recover from stroke. Secondly, we have Dr. Brodie Sakakibara, a postdoctoral fellow from the Department of Physical Therapy in the Faculty of Medicine at UBC. Brodie's research focuses on chronic disease management, for secondary prevention after stroke and cardiovascular disease. He also researches alternative models of healthcare delivery, specifically on the uses of telehealth and readily available consumer technologies such as the internet, computers, and mobile devices for the delivery of chronic disease prevention programs. So welcome, Brodie. He's a long time, grew up in Vernon, but back home to be with us tonight. So that's great. I also want to introduce Dr. Andis Klegeris, Associate Professor of Biology at the Irving K. Barber School of Arts and Science at UBC Okanagan. Dr. Klegeris obtained a PhD from the University of Oxford in the UK and completed his postdoc training at UBC in Vancouver. He's currently an associate professor of pharmacology at the Department of Biology on our campus, and his research focuses on immune mechanisms of the brain and their contributions to various human neuropathologies. Next, I'd like to introduce Dr. Harry Miller, who's a clinical neuropsychologist from Interior Health and a clinical assistant professor of psychology at UBC Okanagan. Dr. Miller completed his PhD at the Ohio State University in Columbus, Ohio, and an internship at the Henry Ford Hospital in Detroit, Michigan. He's department head for psychology and neuropsychology at the Kelowna General Hospital, where he provides neuropsychological consultation for patients who've experienced stroke. Dr. Miller also teaches neuroscience and clinical neuropsychology and is a clinical instructor and site director in the Faculty of Medicine in the Southern Medical Program at UBC. His research interests include assessment of memory, hemispatial inattention or neglect, and the relationship between cognitive deficits and functional outcomes post-stroke. Finally, I'm delighted to introduce Jen Upshaw. And Jen Upshaw is a PhD student at UBC Okanagan studying clinical neuropsychology under the supervision of Dr. Miller and Dr. Maya Libin. Her dissertation research focuses on stroke patients and a phenomena called hemispatial neglect. Jen's research is funded by the Canadian Institutes for Health Research, and she hopes it will ultimately lead to improved recovery outcomes for stroke patients. And tonight we'll hear about some of her research. So that's your panel, and as you can see, we've been able to organize quite a range of experts to join us tonight. So I'm going to stop talking, and I'm going to turn it over to Jennifer Monaghan to provide the first remarks. So we've given each person 10 minutes. So, Jennifer, thank you.
When my stroke happened at the age of 43, I had just driven my daughter home, sent her upstairs to bed, and then as I stood in front of my husband, no words would come out. At first I thought I had just lost my voice. I had no idea what a stroke was, didn't know anyone who had ever had one, and it certainly never crossed my mind that that was what was happening to me. But then I also lost the ability to use my right side and fell to the floor. Also, luckily for me, Dr. Falconer, a neurologist, was in the emergency room that night, and as a result of my devastating left middle cerebral artery thrombus, most likely embolic at my age, I received TPA, the clot-busting drug. So began my stroke survival story. In terms of risk factors, I had none. I was a non-smoking, slim, physically active, low blood pressure, low cholesterol, living a low-stress life, healthy eating, young person with no family history and no previous strokes. But I couldn't sidestep the fact that it had happened, and as the driven person that I was before, I was driven to overcome the effects of it. While in the hospital, I began to regain the use of my right side so I could walk, but balance and coordination, as well as strength and endurance, were a huge problem. My speech was badly impaired. I stumbled over simple sentences, couldn't find the right word I was searching for. I was only able to name 1 out of 10 simple objects, and constantly used the wrong words without realizing. And for some reason, marshmallows were a word I used all the time, out of context, of course. This was particularly hard for me because in my academic and professional life, words were everything. My thinking was jumbled. I couldn't ace the tests Dr. Miller's team of neuropsychologists gave me, like I usually did all tests. My memory was awful. Numbers were like a whole new language for me, and I couldn't even tell the doctors how old I was or what day it was. Fatigue was a constant fact of life for me post-stroke. Fatigue is one of the most common effects of stroke. It is different than being tired or not having slept well. I lacked energy and frequently needed rest breaks. Upon discharge from the hospital, I started looking for resources to further my rehabilitation. I already knew an excellent speech therapist, so I started working with her 3 times a week for an hour privately. I spent a lot of time relearning the alphabet and how to count by 2s up and down. I randomly chose a physiotherapist from the Yellow Pages. Luckily, he gave me the name of another physio who had experience working with stroke survivors, and I started working with him privately. I also already knew someone who worked at the local Heart and Stroke Foundation office, so I went there looking for programs or help with my rehabilitation. 5 years ago, she had nothing for me. Recovery from stroke is a challenging time for all patients. I always enjoyed a challenge, and this was no different. I didn't accept that I would stay this way, so I began trying to get back what I had lost. I simply started using my weakened side repeatedly as much as I could. I returned to the Pilates studio, working slowly with my instructor. I walked my dog. And I tried to return to be the social organizer of my friends, making dinner plans. After a few years, I even returned to the driving range and the golf course, mind you, with a lot shorter swing and a lot farther off target. My kids were obviously traumatized by what had happened to me, and at times more than frustrated by my difficulty speaking. But we all expected me to get better. My mom moved in with us to help take care of the family. I was fortunate to have such great support from friends and family. Friends would come over to visit and make a meal for us, and they understood that midway through, I would have to go off for a nap. Depression caused by the significant emotional impact and by the injury to the brain is very common after stroke. Both the survivor and their family can feel this way soon after or even years after. Gaining knowledge about strokes and talking with your healthcare team, other survivors, and your family about how you feel can help you deal with it. My family and I are very grateful for the incredible medical care I received and for all the opportunities to work on my rehabilitation. What would I say to others who had recently suffered a stroke? This sucks, but maintaining a positive outlook was key to my recovery, and from the many, many survivors I have now met, is a key factor in a successful, confident life after stroke. Kelowna, fortunately, there are lots of resources to enhance recovery. The Kelowna General Hospital runs a stroke and TIA clinic, which is an excellent opportunity to meet with the stroke nurse and doctor and ask questions after being back in the real world out of the hospital that I wish I could have had. KGH has also partnered with the city to offer stroke navigators for survivors to talk to a physical therapist about what they can do to increase their activity level, as well as offering speech therapy groups at Parkinson's Rec Center. I have begun a peer visiting program at the hospital. The Heart and Stroke Foundation runs Living with Stroke classes, and together with the hospital, monthly Stroke 101 classes. The Stroke Recovery Club meets weekly and offers a chance to connect with other survivors. For several years, the BC government has also run stroke collaboratives, where up to 100 healthcare professionals from across the province work together towards achieving stroke best practices. There is also a new awareness of the signs of stroke from the Act Fast marketing effort. Is your face drooping? Can you raise both arms? Is your speech slurred? It's time to call 911. Websites like strokerecovery.guide, strokeengine.ca, and heartandstroke.ca are all very helpful. Taking advantage of all of these opportunities is the beginning of a self-managed journey where you play an active role in your health and recovery. After my stroke, I spent countless hours trying to learn about what had happened to me, why it had happened, and what I could do to get back my old self. I couldn't learn very much from the internet. The doctors couldn't give me a definite answer about why I had a stroke, and I am still trying to get back to normal. I believe that I will continue to recover because of neuroplasticity, the brain's ability to reorganize itself by forming new neural connections throughout life. On my path, there were times when I improved by leaps and bounds, times when nothing changed, and times when I went backwards. That is normal. If I had stopped exercising, stopped working on my speech, stopped engaging with others, or using my right side, that in itself could have impaired my brain. I also spent many hours trying to find research trials I could participate in to improve both my speech and right side deficits. We were willing and able to send me anywhere that might be conducting research in my problem areas, but could not find any potential trials. We need a centralized resource on stroke research worldwide and how to participate in them. And as a younger stroke survivor, I would also like to see research into what I can expect 10, 20, even 30 years after my stroke. 5 years after I had my stroke, I started developing arthritis, all in joints on my right side, which was the side affected by my stroke. And having a stroke puts me at a higher risk of developing dementia. I would like to see research into what to do about these potential future problems. But the good thing about having a stroke for me was that it gave me a focus, and now I am an active volunteer for stroke recovery. I facilitate the Living with Stroke program, which is an 8-week free opportunity for survivors to learn about strokes, share their stories, and feel like they are not alone. At KGH, I visit with survivors before they are discharged to offer them a chance to talk about how they're feeling with someone who has been there, done that. I attend the Stroke 101 and speech therapy group classes at Parkinson's to give survivors hope and encourage them to join the Living with Stroke groups. And for the past year, I went to weekly meetings and many full-day conferences with the BC government's Stroke Collaborative to give health professionals the patient's perspective on improvements to the healthcare system. So far, the government's focus has been on acute care and rehabilitation. Next, they will deal with community participation and reintegration, which is very important to me personally, so I look forward to helping with that. Keep a positive outlook. With help from your family and healthcare team, stroke survivors can work towards living well after stroke. Thank you.
Thank you very much. Now we'll hear from Dr. Sakakibara.
Good afternoon, everyone. So my name is Brodie, as Dr. Bordroff mentioned, and before I start, I'd just like to thank Dr. Bordroff for the invitation to sit on this panel and talk about what I feel is a very important and timely topic. My discussion is going to focus on stroke prevention from both a primary and secondary perspective, with an emphasis on the use of healthy lifestyle behaviors for stroke prevention. I'm just going to start my discussion by providing you with a few facts and figures about stroke to further emphasize why this topic is actually pretty important and timely right now. After 55 years of age, 1 in 5 women and 1 in 6 men will experience a stroke. Now, given our aging population, the expectations are that we're going to be seeing more and more stroke events in the years to come. Many of these individuals will regain independence and go back to community living, and many sorry. I'll take a peek here. So we are going to actually be seeing quite a few more strokes in the near future. Now, there have been amazing advances or medical advances in the acute and subacute phases of stroke, which have increased our survival rates. In Canada, 83% of people who have had a stroke will survive that acute event. Many of these individuals will regain enough independence to continue and go back into the community for community living, albeit many will have physical and functional limitations. Now, of these stroke survivors, 13% will have a secondary event within the first year. 33%, or 1/3 of these stroke survivors, will have a secondary stroke within 5 years. And so I think efforts to promote both primary and secondary prevention is definitely increasing in importance. Now, if we consider or talk about stroke prevention, there's several things that we have to consider. One is we have to have knowledge of what the stroke risk factors are. Stroke risk factors are, or risk factors in general, are the things believed to cause a certain or lead to a certain disease or disability. So stroke risk factors are those things that are believed to lead to or cause a stroke. And the stroke risk factors are really the same for primary strokes as well as secondary events. A key difference, however, is that secondary prevention might be considered a little bit more difficult given the physical and functional limitations that people with first stroke have. It might make it a little bit more difficult for them to engage in preventive efforts. So once we have knowledge of what the stroke risk factors are, then we have to identify which of the stroke risk factors have the potential to be modified, or which of the stroke risk factors can we change. Because those are the risk factors that we could develop programs for, which people can take and hopefully reduce the risk of having a stroke. So they'll take the program, improve those stroke risk factors, which will in turn reduce their risk of stroke. Now, one of the most important research studies that has focused on stroke risk factors is called the Interstroke study. This Interstroke study was published in a very reputable journal called The Lancet. And the researchers in this study, they recruited 3,000 individuals who have had a stroke from 22 countries around the world. And they found that 10 modifiable stroke risk factors accounted for 90% of the risk of stroke. Now, if you take a look at these 10 modifiable risk factors, you can actually categorize them into two broad domains. One of them is health behavior or lifestyle behavior related factors, and the other domain has to do with physiological factors. Now, the behavioral or lifestyle risk factors include things such as physical inactivity, poor diet and nutrition, smoking, excessive alcohol consumption, poor management of stress as well as depressive symptoms. The physiological risk factors include high blood pressure or hypertension, high cholesterol, glucose intolerance or diabetes mellitus, as well as being overweight or being obese, body composition. Now, what's important about these risk factors is both the behavioral and physiological risk factors, they both have direct effects on stroke risk. What's important about the behavioral risk factors is that it not only has a direct effect on reducing the stroke risk, it also has an indirect effect through its positive association with the physiological risk factors. So for example, increasing physical activity will benefit people by reducing their stroke risk directly, as well as decreasing blood pressure, decreasing their cholesterol levels, increasing glucose tolerance, which all in turn will further reduce the risk of stroke. And the Interstroke study, the authors corroborated this paradigm, this holistic paradigm where focusing on health-related behaviors is probably the most important. Whereas in their conclusion, they suggest that targeted interventions to promote physical activity, to increase diet and nutrition, or to improve diet and nutrition, stop smoking, and to lower blood pressure will substantially reduce the burden of stroke worldwide. So the holistic approach to stroke prevention for both primary and secondary is really to target health-related lifestyle behaviors, which in turn will lead to improvements in the physiological risk factors and eventually lead to a reduction in stroke risk. So to answer the question, does healthy lifestyles reduce the risk of stroke? I think there's quite a bit of empirical evidence to suggest, yes, there is, as well as there's quite a bit of conceptual reasoning to think that, healthy lifestyles will definitely reduce the risk of stroke, as well as many other types of chronic conditions. And so the reasonable question following this is, if healthy lifestyle behaviors is so important, then how do we go about changing our health-related behaviors? How do we change our physical activity? How do we increase our physical activity levels? How do we change our dietary patterns? Importantly, or equally important, if not more important, is the question, once we change our behavior, how do we maintain those changes for the long run so that we can experience the long-term health benefits? And these questions are, these are key questions that I try to address in my research. One of my research studies that I have is called the Stroke Coach. Now, this is a telehealth intervention to promote healthy lifestyles after stroke. So this is a secondary stroke prevention program specifically for people within 1 year post-stroke. The telehealth intervention bit refers to that this program is delivered entirely using communication technologies. In this case, the program is delivered using a telephone. And I'll talk about the telephone bit in a second, but before that, as participants in the Stroke Coach study, participants receive education about their stroke, education about stroke risk factors, the benefits of changing their health-related behaviors, as well as the risk of not changing their health-related behaviors. Participants also receive a self-monitoring kit. Now, in the behavioral literature, self-monitoring of various health-related behaviors and other indicators is probably one of the most important things that people can do to change their behavior and sustain those behavior changes over time. So in this study, we give participants a Fitbit pedometer for them to keep track of their daily walking physical activity. We also provide our participants with a blood pressure monitor to keep track of their blood pressure, as well as a physical activity and food and diet agenda so they can keep track of their activity levels as well as their dietary intake. Another key component of this self-monitoring kit is we provide individuals with what's called a health report card. Now, after we interview our participants, we're able to give them a letter grade ranging from A to F on all of their stroke risk factors. We provide them with information about what each letter grade means, as well as what's needed for the transition between each of their letter grades. Also, as part of this program, they receive lifestyle coaching. Now, in this 6-month program, participants receive 7 telephone sessions with a trained lifestyle coach. This coach provides them with education. The coach goes through their health report card with them to identify stroke risk factors with a low grade that could be improved upon, and then the coach works with them in a collaborative manner to identify long-term health report card goals, and then also helps the participants to develop short-term strategies that they could work on in between the telephone sessions. A key purpose of the coaching is to really provide the participants with education as well as motivation to change for the better and to empower the individuals to manage their stroke risk factors for the long run. This is an ongoing study. We're looking to recruit 120 individuals. Right now we have about 85 individuals recruited, and we're probably going to finish the study in October. So I don't have any results right now to share with you, but of the exit interviews that we've conducted with some of the participants who have completed the Stroke Coach program, they have really said that they've appreciated the program, and specifically with the coaches to sort of hold them accountable for completing or following the action plans that they were going to do. So subjectively, participants really have benefited and improved their lifestyle for secondary stroke prevention. And I noticed that my time is up here, so I'll end there.
Great,
Thank you.
Thank you very much. That was great. Dr. Klegeris.
Yeah, good. Hello, everybody. Thank you for this opportunity. I wanted to start with a question to fellow panelists. I think sitting for an hour is a preventable risk factor of stroke. So let's start by getting up and stretching for a minute. That's my first minute. So.
See, we're preventing strokes already.
Yeah. So All right, you can stretch, and I can, like, if you feel like sitting down, you can sit down. If you don't feel like, you can just not sit down. So, okay, so my name is Andis. I'm at UBCO. We have like a basic research lab. Basically, we do not clinical, but biological studies. And as Dr. Brodie mentioned, that we are like a lab which does neuroimmunology. Now, neuroimmunology is kind of a fancy word for inflammation, right? So now I have a question now for you guys. So if I say inflammation, what is your reaction? How many of you think it's bad? Or like you put up hands, like inflammation scary, inflammation dark, inflammation should be get rid of, right? Okay, so how many of you think inflammation is good? Yeah, put up your hands, okay, yeah. So how many? A little bit less, right? Okay, and what about the rest of you? Are you here just for cookies, like me? Yeah, okay, all right, good. Okay, well, you see, and how many of you put up hands twice? That inflammation. Okay, you guys winners. So, and this is the challenge with inflammation research, that it's good sometimes, it's bad other times, it's good at certain doses, bad at some doses, and it's a very nice introduction by Dr. Sakakibara that there are these risk factors, right? And he mentioned several of them, and it turns out that some of these, which are preventable risk factors, they are actually high inflammation situations. So I carefully wrote down, so things like physical inactivity. So if we are not physically active, basically we become inflamed, and that is bad. Also, poor stress management. Stress is again good at small quantities, but at large quantities it's not good. And also we can become inflamed, and that is not good situation. Of the others, obesity, pre-diabetes and type 2 diabetes situations, also it's associated with a significantly high levels of inflammation in periphery, right? Periphery meaning from here down, right? So, and what we do in our lab, we are trying to understand how this peripheral inflammation can lead to increased risk for stroke, for example, right? So one thing what we do is we study mechanisms, and we look at different molecules. For example, we look at glucose, and glucose turns out to be at high levels, enhancing all sorts of inflammatory activities in the brain, which are also not good. Insulin, for example, is another example that in pre-diabetes, it can be basically high levels. Surprisingly, in brain, that leads to low levels of insulin, and low levels in insulin in the brain, again, it's a not good situation because it disturbs all the balances. Other things like incretins, which are kind of peripheral signaling molecules, again, we try to see how they affect immune mechanisms in the brain. So that is one area of research. So now practical advice from this is really you have to try and stay less inflamed. So there are simple things how you can do that. For example, oral hygiene. That is one thing. Also, not being stressed too much. Being physically active. Keeping your weight under control, right? All these things will basically prevent, as I heard, stroke, but many other diseases. For example, we focus on Alzheimer's disease. The same preventable risk factors. Yeah? So you do the same thing, and you have like 2-for-1 situation, right? You prevent stroke and you prevent Alzheimer's disease at the same time, and you don't need to do many other things. Okay. Another interesting way how you can prevent stroke, which I learned, which also illustrates this situation about inflammation being good and bad. It turns out that if people have these serious inflammatory situations, or maybe sometimes like not like maximally serious. For example, respiratory illness. I have like cold at the moment, right? I'm at higher risk for stroke now. At the same time, I have lowered my risk by receiving vaccine. I vaccinated myself against flu. And there's a very strong evidence that vaccination actually is preventative. So you can see, like immediately, if you have this shot, like flu shot, your inflammation is slightly boosted, and that's good. But if you stay inflamed and catch colds, then you become basically more at risk for stroke. So another kind of surprising conclusion, wash your hands, right? So you will be avoiding flu and will be avoiding stroke, right? So again, 2-for-1 situation. Okay, so that is one aspect what we do in our lab. Now the second aspect is as follows. Our brain is not only like to create thoughts and so forth, it also has immune system in it. And surprisingly, it is what's known as immunologically privileged organ, brain. Why we know it's immunologically privileged, there are many signs, but one of them that it's very easy to transplant brain. Yeah? Can you imagine? Like if somebody wants to transplant brain, it's pretty easy to do. I will let you reflect on that, right? So your brain's being transplanted, you wake up, and brain's okay because the other body is not rejecting it, right? So that's how it's immune privileged. But the other thing about being immune privileged is that the immune system doesn't work there very well. And there are essentially not many types of cells which constitute brain's immune system. In periphery, we have like these different types of responses and so forth and so forth. And in brain, pretty much we have only just a single type of cell which can launch immune responses. And what happens during the stroke is also the situation where immediately after the event, immune system is probably bad. So it would be nice to calm it down, but then at the long-term recovery, immune system is helping the rest of the brain to recover. Yeah? So therefore these specific cell types in brain which are responsible for immune killing and immune healing, yeah, we need to learn how to manipulate them. We cannot just like give some drug and completely inhibit them, because then we will inhibit good things about them and inhibit bad things about them. So we need to learn how to make them basically not bad, but still good, right? So, and that we are not there yet. So many people are trying to understand how this can be selectively changed. And I think I'll stop here.
Great. Thank you very much. Dr. Miller.
I'm not sure if I want to hold on to this. So you said you had a cold. Actually, I'll just start by saying that I'm a practicing clinical neuropsychologist, and so for my part of the talk tonight, I'm going to focus more on what we do as neuropsychologists, and particularly on the rehabilitation unit at Kelowna General Hospital. The one thing I want to say, and Brodie's talk reminded me of this, one of the pieces of research that we did a few years ago looked at caregivers and caregivers who are caregiving for someone with a stroke. How many are in that position now that are in this audience? Okay. So it's invariable that will be a function for some. And the research that we did, and the reason that Brodie's talk brought this up for me, is that we had looked at caregivers in terms of in-person support and having a group along those lines versus those that were receiving support at a distance. And it makes sense when you're in communities where somebody isn't able to get to the site, that could we look at delivering the care in a different form. So what we did in brief was look at it in terms of a telephone caregiver support group. And our research actually compared the efficacy of an in-house or a group where they received in-person caregiver support versus by telephone. What do you think the results look like?
Can
Okay, anyone else? Yeah, so most people would think that in person would be the better and would get better results. And in fact, our research demonstrated that they were equivalent. There was no difference. And there was actually a tendency or a trend towards the distance education caregiver support group actually having better results. So just as a quick aside, why do you think that might be? Pardon me? No, it isn't one-on-one. It was as a group. So we compared comparable groups just by different modalities. Convenience, probably one. Yes?
I would say, like, because you aren't there physically with the room, you kind of have, I think, less inhibition. And you can really focus on what you want to say because you're not afraid what they might think because they're not there.
That's absolutely the correct answer. When we went back and asked the participants what they thought, they felt that they had more anonymity and they felt freer to discuss the real issues. And as we all know, the more that you can put forward, the more honest and forthright one is, usually you get more out of it. And so while the difference wasn't significant, it was very clear that if not equal, the telephone support and education group may have been a little bit better. So just as a thought, and that's certainly a piece of research that we felt that was very useful and we'll certainly want to try and bring forward here. Now, just in terms of what a neuropsychologist is, just to go back a little bit, we are involved in the assessment of cognitive and emotional functions. And so I'll talk about that in a bit. But in the past, neuropsychologists were very much involved in looking at the locations of strokes, trying to identify where they might be in the brain. We don't need to do that anymore because we have very advanced radiological techniques, including CTs, MRIs, and more than that now. And so our role is really more in understanding the behavioral implications of a stroke. And while a CT and an MRI, for example, are structural examinations, they can demonstrate where the damage is in the brain. Very often they don't identify what the impact of that damage is to the person in terms of their day-to-day function. So neuropsychologists are very much involved, and that's my role at the hospital, to truly understand the behavioral manifestations of that particular insult to the brain for that particular individual. Now, just to step back a bit, Brodie touched on the incidence, prevalence of stroke. So in other words, how frequent stroke is and the likelihood that it's going to increase. I just want to touch a bit on what types of strokes that we typically see. There are generally two types, and they are really involve the ischemic or the hemorrhagic. And ischemic can be broken down into two further subtypes. One is related to thrombotic and the other is to embolic. Embolic is really where you have a clot, and that's the one that Jennifer referred to that may be the source of her type of stroke, where a clot that originates somewhere in the body, and often it's from a cardiac source, will make its way through and ultimately lodge in a vessel and cause a stroke. The vessels in the brain tend to be smaller, and as that clot moves through, that blockage then produces some of the issues that Jennifer clearly elucidated. The other way is through having more the thrombotic or the narrowing of an artery through plaques that are usually formed because of fatty substances. And as that artery narrows and you have a reduction in blood flow, you then ultimately have areas in the brain that no longer receive the necessary nutrients that are delivered via the blood, and you can stroke in that manner. The other type is the hemorrhagic, and hemorrhagic stroke really refers to an outpouring of blood. So there's a rupture in a vessel, and that vessel ultimately has some weakening, and high blood pressure is one of the major risk factors for that weakening of the vessel, and you can then have a stroke by having blood pour out into the brain. Different subtypes of hemorrhagic strokes, and one may be as a result of the rupture I just talked about. You could also have an arterial venous malformation, or more commonly known as an AVM, which is a tortuous mass of vessels that can ultimately rupture again because of weakness, and you have that pouring out of blood. You can also have a subarachnoid hemorrhage, and that's a dispensing of blood between the lining of the brain and the brain itself. Now, some might think, well, that may not be so serious, but in fact it is, in the essence that it ultimately causes pressure on the brain, because the brain doesn't withstand pressure very well. And that collection of blood will ultimately create that pressure that, if it's sufficient or significant enough, will need to be removed from the brain. Now, there are two other factors that we can talk about in terms of the hemorrhagic, and they can be intracerebral, and that means within the brain, or the subarachnoid type, which is outside the brain. So intracerebral really involves having bleeding inside the brain from one of the major vessels that supplies the brain. Now, just in terms of the actual arteries that get affected, very often it's the three major arteries, and that involves the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery. And these three major arteries, when they're affected, can lead to different kinds of consequences. And if you have, for instance, a middle cerebral artery stroke, as Jennifer referred to, she will probably say to you that it affected her arm more than her leg. Yes. And that's just because of the distribution of the blood flow. As the blood supplies the brain, distribution of the middle cerebral artery feeds that area from a physical standpoint. But if you look at the aspects of left and right sides of the brain, the left side of the brain tends to control more language functions, more verbally mediated functions, and in Jennifer's case, as she mentioned, the language aspects as well. The right side tends to be more visual spatial, but controls the left side of the body. And in essence, you'll have some different types of effects that occur. Now, we can talk about these different issues that we know in terms of the types of arteries that are affected or the side of the brain that's impacted. Wow. 8 minutes goes quickly. Jennifer will give me some time, I'm sure. The point being that we can know in general what happens when we know the distribution of blood supply that's affected or the side of the brain that's affected. But it doesn't tell us everything, and that's where the neuropsychological evaluation comes into play. So when we assess patients, we look at different domains. The primary domains will be learning and memory, attention and concentration, visual spatial skills, problem solving and reasoning, and language function. And by doing so, we develop a better understanding of how that particular stroke impacts on that individual. And then we try to draw some appreciation for how it's going to impact on that person now and in their day-to-day life. So the assessment itself constitutes three basic premises. One is that we review documentation, so we understand what happened to the person. The second is to do a clinical interview to appreciate who that person is before and then following the stroke. And then we do what I think most people refer to as the neuropsychological evaluation, which really is a series of tests to look at the cognitive and emotional issues. But it's really the combination of all of those factors as you bring them together that really is what constitutes a neuropsychological evaluation. Now, in terms of what we get asked, the questions that we get asked, in particular, we're asked to understand the consequences just from a cognitive emotional perspective, but as well, we are asked whether or not a person can return to independent living, whether a person can return to driving, whether that individual is able to go back to work. Is that person able to consent to various different types of treatments? Can they make decisions from a legal standpoint? So there are multiple issues that we become involved in, and the reason that we're requested to do a neuropsychological evaluation. From a rehab perspective, it helps to drive treatment. So we will do these assessments and then work with the rehab team so that rehab team, which involves a physiotherapist, occupational therapist, speech language pathologist, nursing and so on, so that they understand the cognitive emotional effects of the stroke, and that will help them to better assist the patients in their recovery. And I think I've got a pretty good message there that says stop, so I'm going to turn it over to Jennifer. Thank you.
Thank you. Thank you very much. There'll be more time if you've got questions. There's a question period, and so write them down. And I'm going to turn it over to Jen Upshaw now. Thank you.
Awesome, thank you. So my name is Jen. I'm a clinical psychology graduate student in the UBCO program for clinical psychology. I'm doing my PhD currently, and my dissertation research focuses on specifically neuropsychology. So that's kind of my focus there. So I am Dr. Miller's graduate student. He supervises me. So I've had the great fortune of working with him and also with a very large population of stroke patients that we do see on the rehabilitation unit at KGH. And so that's been really a very rich source of data for me for my research, which is what I would like to tell you about tonight. So my research focuses on stroke, and more specifically within stroke, my research focuses on something called hemispatial neglect, or just neglect. So tonight I'd like to give you a little flavor of what I'm doing on my very small portion of the front lines of neglect research and stroke research here in Kelowna. So when I say neglect, it kind of brings to mind someone's being neglected, we're being neglectful, those types of things. But when it comes to stroke, it's actually quite a different definition. So with neglect, when someone's had a stroke and they have neglect, it's actually an attentional issue that has some pretty severe consequences for that person's perceptual world. And so when a stroke patient has neglect, they're essentially ignoring one side of space completely. It's usually the left side. We don't usually see a right-sided neglect. But what that patient is doing is completely not paying attention to that one side of space. So it essentially doesn't exist for them. So as you can imagine, that could have some pretty serious consequences if you're really not aware of anything that's happening over in sort of your left visual field at all. So what does that look like? We see patients on the rehab unit that have neglect. They'll be sort of crashing into walls on the left side of space. They'll be crashing into door frames, things like that. We see them failing to notice people who are standing in that neglected visual field. They won't notice objects that come moving into that side of space either. They may actually only shave or apply makeup to one side of their face, which can be very unusual. You can see someone with, half a beard on their face, and it's probably due to the neglect. They also may not dress one side of their body. They might leave arms out of sleeves or legs out of the pant legs of their clothing, and that can be very unusual as well. And Dr. Miller and I like to reminisce about one patient that we had who was very aware of his neglect. He was very insightful, and he would only eat off of one side of his dinner plate, and he would like to say that when he was still hungry, he would just turn his plate 90 degrees, and he had a whole nother meal to be able to eat on the other side. So these are kind of funny, quirky examples of what neglect can look like, and it's kind of amusing to think of it. But in reality, neglect is actually associated with some very severe consequences as well. And so if you can imagine, someone with this neglect syndrome is out in the community, they're crossing the street, they're not paying attention to that left side of space. They may step out into traffic when a car is coming straight at them. It can be very dangerous. In the hospital, we know that patients with neglect have poorer recovery, slower recovery. They're going to stay longer in the hospital, and they're going to be less likely to be discharged home ultimately. If they do get home, they're more at risk for falls, more at risk for injuries. They have poorer return to independent living and sometimes have to go to assisted living facilities more often. And they have poorer self-care and poorer locomotion, which you can understand. If you've got sort of no awareness to that side, it would be really impactful. So it really is quite hard for patients who have this disorder. And even though it is very debilitating, we don't know much about it. And it's actually really common too. I should mention that we've got this neglect symptom sort of showing up in about 2/3 of right hemisphere stroke patients. So that's a significant number of our patients that we're seeing this in. So even though it is that common and even though it is that debilitating, we really don't know much about it. So nobody's really talking about it, nobody's doing much research on it, and we're not really assessing for it in the neuropsychological setting as much as we should be. And so one of the reasons for that may be because neglect can actually be divided into different subtypes. And so I'm going to tell you 2 of the subtypes because it is relevant for my research and it's kind of confusing, so bear with me. So one of the subtypes is called egocentric neglect. So if I have egocentric neglect and I'm looking out across this room, I'm going to miss out on the left side of everything that's happening in this room in general. So I'm not going to see you guys over there. I'm not going to be paying any attention to you over there. I'm really just focused on this side. Now, if I have allocentric neglect, this one's a little bit different. I'm seeing the whole scene, I'm paying attention to the whole scene, but I'm only seeing half of individual objects within that scene. So I'm seeing half of this table over here, half of the lamp over there, half of the dessert table over there. So half of all of those items is essentially cut off for me. I'm not paying attention to it. So these are very different presentations, but unfortunately they're getting lumped together very frequently. And so what we wanted to do was differentiate between those subtypes. And so that's what we set out to do. Are these people different? Do they have different behaviors? Do they have different functional outcomes? And so that's what we set out to do. So what we did is we got this really cool, really novel eye tracking system. So this samples our patient's gaze, where they're looking in space, and essentially tells us what they're paying attention to and what they're ignoring. So we had our patients sit down and do a task where they would, cross out apples on a page, do all these things that are supposed to tell us what subtype of neglect they have, and then we would look at the attentional patterns that came out of that. And we also assess their functional outcomes, so how they're doing emotionally, how are they doing cognitively, how are they doing physically, all of these things that are really important for living a good life. And so we found 3 really cool things from this research. The first one is that our eye tracking assessment, this really new, really cool assessment, was actually better at picking up neglect in patients than any other measure that we tried. So this was able to identify really subtle neglect in people, whereas they would have appeared as normal on other measures. And so that's really important because these impacts, even though they are subtle, are having, pretty serious impacts on patients' lives. So it's good that we can identify them. The second cool thing that we found is that the attentional patterns that we're seeing in neglect patients are actually quite different than we thought. So it turns out that someone with neglect, there's not some sort of invisible barrier at midline beyond which their gaze won't stray. So it's not like they stop here and then kind of go back, stop here and go back. Their eyes actually do get over to that neglected side. The problem is they just don't stay there. And so that has really important implications for treatment. Can we capitalize on that? And I'll talk about that in a moment. And then the third thing that we found is it actually seems to matter which subtype of neglect you have. So if you're very lucky and after your stroke you don't have neglect, you're going to do best. If you have egocentric neglect, you'll do slightly worse. If you have allocentric neglect, remember missing out on sort of individual halves within that scene, you'll do even worse. And then if you're really unlucky and get both subtypes of neglect, that's when you're really going to fall off functionally. So there was kind of this nice curve of function on how people were doing based on the subtype of neglect that they had, which was really cool to see. So those are kind of interesting findings for someone like me because I'm a dorky researcher, but what does that actually mean for patients? What does that actually mean for moving this forward? So how can we kind of apply what we've learned and make it meaningful? So now that we know that patients sort of have this pattern of getting their eyes over to that neglected side but not staying there, how can we get them to stay there? That's the key piece that we're looking at now. So what this indicates to us is that early sort of automatic attention and processing in neglect might actually be spared. So can we capitalize on that? Can we sort of train that and make sure that our patients can compensate for their deficits? So we're hoping to use our eye tracker to be able to do that. So for example, we're planning on implementing some treatment strategies using sort of computerized games. Can we use those kind of games to cue people over to that side? Can we not advance them onto the next screen until they've spent enough time on that side? Can we use that visual cueing to really physically actually pull their attention over to that side and get them to stay there? Or can we use potentially real-life videos of crossing the street, of being at home, of being in the grocery store, so that the rehab on the unit is more applicable to their day-to-day life? So that's kind of where we're hoping to go next and what I'm hoping to study for my PhD. Well, it'll take me a million years, but hopefully we'll get there. So the bottom line is essentially that now we know quite a bit more about this neglect phenomenon than we did before. So now we can kind of start to better help our patients to actually be able to achieve their goals, which are to get home, to get back to sort of good, independent living and living the life that they want to. And so we're hoping that we'll be able to help contribute to that. So that's all I have to say tonight. Thank you very much.
Here. And we are going to pass a microphone back and forth among people at the front. So we have a question.
Is it possible to have the TPA more than once?
Does anyone? Yes. So the answer is yes. Okay. That was a quick question.
Always or just sometimes?
Okay, Harry, do you know?
Sorry,
Always.
rephrase that again.
Is it always possible on the second stroke to have TPA?
I mean, the short answer to that is it's not always possible on the first stroke. There are issues that need to be attended to from a medical standpoint before you're considered eligible or not for it, because it can also be quite detrimental to your well-being in certain circumstances.
I don't know if I really need
Oh, yeah.
Oh, yes, you do.
Oh, yes, you do.
You can just, okay, this is for Brodie. You had mentioned just when I wrote it down, the stroke coach, and you
Yes.
said it was up to a year, or after a year of the stroke.
So the
that you were
people,
able to
the
do
people that we're including in this study are within 1 year post-stroke.
Oh,
A reason for that is because the first year is when the highest incidence of secondary events would occur. So 13% of people who have had a stroke will have a secondary event within the first year. And so that's part of the reason why we're targeting that group.
And how long is the intervention?
So the intervention is 6 months long, and in that 6 months you receive, or the participants receive 7 lifestyle coaching sessions with one of our trained lifestyle coaches.
Another question? Yes, go
What
ahead.
if you've already had your second one?
No, that's perfectly fine. I mean, the whole point of our program is to promote healthy lifestyles after stroke, regardless of what number stroke that person has had, because our belief and the paradigm that we follow is that improvements to lifestyle will go a long way to not only preventing subsequent strokes, no matter what number it might be, but also preventing other types of chronic conditions.
Great, thank you for that question. We have another one. Go ahead.
Hi, I have a question for Dr. Miller. You spoke just briefly about your caregiver research.
Yes.
And I was wondering if you could elaborate just a little bit on that. And like, what was your research question? Like, you said that it was successful and you found,
Sure.
that the distance stuff was just as effective. But effective at what?
So the research question was basically to determine the effectiveness of the two groups, so whether it was distance or in person. And the variables that we looked at, the primary one was reducing the level of emotional distress in the caregivers. So that would be the primary outcome that we were looking at. And it really involved dealing with education for caregivers, and then looking at coping strategies to manage as they go through that journey working with their loved one.
I had a question, one for each of the ladies, and I'll just say them first. And then, so first of all, I wondered whether you ever did figure out what was the trigger, why you had the stroke. And then the question I had for you was, I think I understood that you said 2/3 of the people would suffer neglect? Good heavens. Okay, and so to date, is what's been happening is that gradually you just hope and pray and cross your fingers that they get better on their own, and what you're trying to do is speed up that process? Is that kind of what the deal is? Okay.
The doctors couldn't give me a conclusive reason why I had a stroke.
All right, that's a great question, thank you. So 2/3 of right hemisphere stroke patients, so that's half. So 2/3 of half of our patients, just because we don't usually see neglect with a left hemisphere stroke, and there's some different reasons for that. But yeah, you're right, we typically are not assessing for neglect. It's not part of our regular assessment battery, so usually these people will just kind of have a note in their file that they may be a bit neglectful on that left side of space, but it's not typically a target for treatment other than, maybe trying to remind them once in a while just to look over to the left or make sure you're using that left arm, and that's usually the extent of what's done for those patients, unfortunately. Yeah.
I can maybe just add to that a bit. So neglect is an interesting phenomenon, as Jennifer has talked about, and it really is that inattention or unawareness of that side of space. And one might think that you could just simply ask somebody to look over there, to attend to that side, but it doesn't work very well because of that complete unawareness of what's happening. And one of the ways that I try to have people understand what neglect is really like is to, as you all sit here, imagine what's happening behind you. And all of you know that there's something there, but there's no conscious desire to turn around and look all the time to check. And that's what it's often, or at least what we think it's like for somebody with neglect. And as Jennifer's mentioned, it's typically to the left side. That side of space, while it exists, it doesn't exist. And it's different from something that some of you may be aware of, which is a visual field cut, where you actually have damage to the visual system where you are unable to see over there. That's a visual problem, which is quite different from what Jennifer's talking about, which is an attentional problem. People with the visual field cut will actually look over there if they're instructed to, because they ultimately know that something exists and they need to simply turn their head, and it works for them. But it doesn't in the sense of neglect.
I have a question. First one for Jen, just going off of the last one that was asked about the 2/3 of stroke patients in the right hemisphere have left hemispatial neglect. Does that mean that if you have a stroke in your left hemisphere, you're much less likely to have hemispatial neglect?
Yes, that's absolutely true. So the kind of biological reason for that is based on sort of how your brain allocates attention to different areas of space. So your right hemisphere has this bilateral control of attention. So your right hemisphere can pay attention to kind of both sides of space, whereas your left hemisphere just pays attention to the one. So if we get a stroke to the left hemisphere, you've still got that bilateral control that's coming from the right hemisphere, so you can kind of compensate for that loss of attention from that side. Whereas if you knock out the right hemisphere with a right hemisphere stroke, you've lost the bilateral control, and then you only have the contralateral control coming from the left side. So you've only got attention over to that side of space. So that's why we just see it on that one side typically. Yeah, great question.
Thanks. I have another one actually, if you don't mind. I was wondering what the TPA or TPA treatment stands for?
Tissue plasminogen activator. So it basically is a clot buster.
Is there any difference with people that are left-handed versus right-handed effect of a stroke on either side of the brain?
Take it away. I know you have the answer to this.
Possibly. And I'll give you a bit of a reason for why that is. So I'm going to ask a couple questions here. So how many people, first let me start this. Language, for instance, is represented on the left side of the brain in the vast majority of people who are right-handed. So about 99, 9/10, almost 100%. So what do you think the number, percentage would be for left-handers who have language on the left side of the brain? And it's kind of key to the answer.
20? 50? 90?
About 70%. So if you're a betting person, you're going off to Vegas and you get this question, I don't know why you would, just always answer that language is on the left side, regardless if you're left or right-handed. So the issue here is that if you are left-handed, language being represented most of the time on the left side, but you still have 30%, which will be different from the right-handed person. And of that 30%, half will have language represented on the right side of the brain, and the other half, so 15% of the total, will have language bilaterally represented. So potentially, if you have a stroke, depending on the hemisphere that's affected, you may or may not have a significant impact on language if you have a left hemisphere stroke in a left-handed person. Does that answer your question?
Great questions. Other questions or comments?
I was waiting for a pause. Andis, I have not heard a question asked from you, so I'm just going to say you briefly touched on sort of the peripheral inflammation versus the central inflammation. And do our lifestyle choices make a difference in how we reduce both types of inflammation? And another question to that is the central inflammation or the peripheral inflammation in a chronic state, which is most detrimental to us?
Very complex question. Well, I'll try to break it in central and peripheral parts, right? So in periphery, I think in most cases it is detrimental, and it kind of also interesting that we know that in classical situations of inflammation, we know there is inflammation, right? So, for example, if people have some arthritis, right, they would take drugs because there's pain and they know there's inflammation. And that, on one hand, makes peripheral inflammation kind of treatable. Probably the only place where we don't feel inflammation in periphery are arteries, right? So, and that's, for example, all these kind of cardiac issues come in. Now, some people would say that in brain there could be inflammation which is much, much higher than in periphery, but because brain doesn't feel pain, brain only feels pain in periphery, right? The brain doesn't feel pain when it's coming from inside the brain, right? So, therefore, like all the inflammation in brain, actually we don't feel.
And we don't treat
and
early.
Yeah, so people who have their knees hurting, they would go and buy drugs over counter. People who have even higher inflammation in the brain, they just not aware. But in the brain, I think the chronic situation, long-term situation, in most cases, is not good. At the same time, for example, stroke recovery. On one hand, you would think that you want to inhibit all the time, but during stroke recovery, apparently, you should not do that because the immune system is actually helping regrow nerve cells. So, and that is the complexity.
Thank you.
Thank you for the question.
And I'm sorry, but I have one more. Harry, one of the things you did talk about, and Jennifer sort of led to your discussion, was just that we do really much better in sort of our physical functional services for rehabilitation post-stress stroke. And you didn't get a chance to talk too much about some of the things that are up and coming in terms of like Jennifer said, self-management tools for people to work on the cognitive and emotional sides post-stroke. Things that, you know, often when we talk to stroke patients, they feel like we are focusing most on their physical function and not their cognitive function. And could you have just a little discussion on how we're trying to give cognitive, emotional memory tools for people to manage, like Jennifer did, that self-management of that part of their recovery? Thank you.
Not sure where I want to start. It's a challenging question, and it's challenging for a variety of different reasons. The research is still, in large part, in its infancy, in terms of looking at more the restitutional aspects of cognition. The second component to that is that the resources that we have available, and these are typically resources always boil down to financial, and then they translate into people-type resources. We're quite limited in that regard too. But if I talk about it in a more general sense, we typically talk about cognitive rehabilitation from a compensatory and a restitutional standpoint. Compensatory is much easier to understand in that we can use, if we use memory as a target, we can look at strategies such as using lists and notes, keeping a day timer, keeping a bulletin board, or now we have the advantage of using technology. So you can use your smartphone, your iPad, your computer, various different ways to help you to remember. Most of us use those devices anyways. So the nice part is that today, if you have a significant memory deficit, it doesn't look like you're doing something unusual because you're just doing what everybody else is. With the technology, you have the ability to not only scribe, but you can take pictures, you can voice record. So it really does help people to compensate for the memory issues. And we do have opportunities to teach people ways to use those strategies in a very functional manner. And that can apply across the board when we look at not just memory, but the ability to pay attention, to focus and to concentrate, to manage decision making. So looking at steps that you go through in terms of making decisions or planning and sequencing activities. So compensatory strategies involve the types of techniques I just mentioned, but you may also modify the environment. And for some of you, you may be very much aware that if there's too much stimulation, it impacts on your ability to carry out activities. So if you reduce the stimulation in an environment, you work one-on-one with somebody, it changes your functional capacity. If you're a student, and you're going back to school. You may choose to sit at the front of the class. You may choose to have your exams taken in a quiet room. You may have notes prepared ahead of time, or you may record the lectures so that you can process them at your own speed at a later point. So there are many ways that one can compensate, and we do assist patients with that. What I'm most interested in, though, and I suspect most of you are too, is how do we restore the ability that we seemingly have lost, or the ability that's diminished from what it was before. And that really touches on, I think, what Jennifer was alluding to, and that's that issue of neuroplasticity. And it's a bit of a buzzword, and often we're not certain what it really means when we say it. But from my standpoint, what it really implies is the ability to reorganize, change, and develop new neural networks that will subserve those cognitive abilities that the stroke has otherwise damaged. And so now we don't have that normal pathway in terms of what we need to mediate memory, or the ability to attend, or the ability to manage a number of different things in a sequential manner. The challenge with restitution or restorative types of techniques is that you require a lot of time and someone that can work with you on in terms of repetitive activities. One of the ways that I try to relate this to individuals, that does anybody in here golf? Anybody chase a silly white ball around okay. So anybody in here taken golf lessons where you try to learn a new golf swing? Okay. How successful have you been? And that's typically the response. And what happens is that people will go to the lesson, they'll do reasonably well in the lesson, the coach works you through it, you seem to be able to hit the ball straight, and then what happens when you go to the golf course the next day? It goes all over the place. So the point of that is that if you simply go to a golf lesson and then you don't practice exactly what you did in that golf lesson repeatedly that day, the next day, and the next day until you get to your next lesson, there's nothing that really happens. You have only a transient change. The only way that you will develop a durable change is to practice that particular activity over and over and over throughout that day, day after day after day. And ultimately, you will start to replace the abnormal or maladaptive behavior with the proper one. But in order to have a durable change, you have to change at the brain level. And that's changing that neural circuitry. And that's that repetitive practice that's absolutely critical. And so to answer Corey's question, at this point in time, we're very limited in having those resources to do that. But those are the very things that we're trying to bring forward from a rehabilitative standpoint to make happen. Because I think if we ask anybody, and I'll actually ask Jennifer, would you prefer to have a compensatory strategy or one that gives you restitution of your ability?
I want to return to what I was.
Yeah, no question. And I think there is opportunity.
Everyone hear that? She wants to return to what her previous ability was, yeah.
And I think that's possible. There is some good research that will look at it from a physical standpoint, where you learn how to walk, you learn how to use arm function or hand function. There's some good research that's out there. The research on cognition is less solid, but we need to be pushing for that kind of research to figure out who the right person is, what type of stroke, what point in the recovery process should we be undertaking some of these activities. Because I will also say that not everybody who has a stroke will benefit from that type of therapy. You still need some ability to develop a substrate. So as perhaps pessimistic as that might sound, it will not work for everybody. But for those that it does and will likely work, we need to figure out how to have that happen.
That's wonderful, thank you. And aren't we all glad that we have UBC researchers here working on this stuff?
So then I guess the billion-dollar question is, how come the healthcare system doesn't do it? So, I mean, I think Jennifer's story is amazing, and it's, recovery was remarkable, but from the sounds of it, you did a lot of it on your own and with resources and support that you had in place because of that was your situation. And so, and I get it that it's not going to work for everyone, but where's the sweet spot between the public health care system providing enough resources so that the maximum number of people recover to the extent that's possible. And yeah, some percentage of the time, you're not going to get any improvement.
Honestly, Paul, I wish we had the answer. I think there needs to be a willingness for us to look at how we deliver rehabilitative services. And right now, we're not there yet. But Jennifer's alluded to the Stroke Collaborative, and there are a number of key people who are willing to now work together to figure that out. And we are actually at the rehabilitative side in trying to look at evidence-based practice. And I think that's going to force us in that direction. But I'm still, obviously, I'm sitting on the fence here a bit because the resource implication is significant. And we need to direct resources towards rehabilitation. But I can assure you right now that healthcare moves resources towards the very acute phases, and the rehabilitative side tends to be second cousin. My argument is this, that, and I don't want to make this sound horribly negative, but if you, and this is putting it in the extreme, but in the acute phase, you live. Your life is saved, so you do live. But after that, most of us are concerned about quality of life. And how do we maximize the quality of our life? Because it's more than just being alive. It's being able to live that life to your fullest extent. And that's where I think the resources need to be moved to that rehabilitative side to help people to develop that skill, the skills, the abilities that are truly, I think, available, but we have not got the resources yet to bring that forward. So Paul raises the billion dollar question, and it will take money. It's not free. So the other question that we have to raise is, and that's sort of a bit of a pun, but are we willing to pay more in our taxes to have that rehabilitative side? And I would probably argue some of us would very much so.
That's great.
Thanks, Paul.
And Brodie wants to add to that.
I'll just add to that in terms of talking from the prevention side. And so Dr. Miller was really focusing on rehabilitation, but I think it goes beyond rehabilitation after people are discharged and back out into the community. So Dr. Miller alluded that, once you're in the acute phase, you survive that phase. 83% of people who've had a stroke in Canada will survive that event. They make advances in the hospital, they make advances in rehabilitation, but then after discharge back into the community, they lose all that support. And so what we're seeing is many individuals who are back out in the community, they lose all the gains that they've made in rehabilitation. In terms of lifestyle, individuals who have had a stroke are discharged and they continue to live lifestyles that contribute to their stroke in the first place. And that's part of the reason why we see such a high incidence of secondary events. 33% of people will have another stroke within 5 years. And so there has to be more resources, not only in the rehabilitation, but also in the prevention side once people have been discharged back out into the community.
Couldn't agree more, Brodie, and I think you're talking about secondary preventions. I think at the primary side of having those lifestyle issues undertaken before one has a stroke. I think that's obviously where we really want to see things happen, is to make those changes before one actually has the stroke too.
So I have a question that kind of leads off from this, and so I'm going to insert myself. So I know there was a comment that more men than women have strokes. So Andis, can you tell me why that might be? Do we have any idea why it affects men more than women? And is their recovery any different?
Yeah.
It's obviously potentially a sex difference. I don't know.
Well, I think, like there's...
women more than men, right? Women more than men?
Yeah.
Women more than men. And I'm assuming it's not just because women live longer than men.
Yeah, that is slightly outside my area of expertise. But probably there are not too many situations where risking, do you have more information?
Not a whole lot, but yeah. But the issue of age is an absolute risk factor for stroke, and women do live longer right now. We're trying to catch up, but we haven't made it.
Yes, that's right.
I mean, age is clearly the #1 risk factor for dementia.
Yeah.
So that's a critical variable. It's one of those non-modifiable. But if you have the alternative, we'd rather live longer.
Yes. Oh, there's one over here.
Hi, I work at a local gym, and I think the question, first of all, Jennifer, wow, what great tenacity and incredible recovery. I had a concussion a couple years ago, and it's interesting to some of the similarities, not anything like what you went through, not anything like it. It was all day to brush my teeth, but I didn't have to learn to do the alphabet again, and wow, that squeezed my heart. Yeah, you're amazing. So I work in a gym, and we see lots of different issues, and I have a lady right now that's there, and she has had a whole bunch of mini strokes. She's back in the gym. The doctor says it's okay. So as people in the gym, we would like to be, that's why I'm here today. My gym actually sent me here. So we could be a better support for those people that do come into the gym. And from your expertise, and I know usually for all of us going to the gym, we work from whatever we're coming in with, you know, our own toolkit, our own level of fitness, health. But is there any guidelines that you would suggest that would be good? So after you're out of the hospital, after you're that person that is finding themselves, oh my gosh, what do I do now? Do you have any steps that would be maybe some even loose guidelines that we could be aware of? Thank you.
Well, I would start by talking to my doctor and getting his or her okay and guidance. And then the other part would be to visit the Parkinson's Rec Center, and there's a stroke navigator there who can talk about physical activity with anyone who had had a stroke.
In the work that I do in developing and evaluating stroke prevention programs, we make our participants aware of the Canadian Physical Activity Guidelines. Those are the ideals. Does anyone know, or has anyone heard of what the Physical Activity Guidelines are? For individuals 50 years of age and older, in terms of aerobic activity, the recommendation is to get about 150 minutes of moderate to vigorous aerobic activity a week, and they suggest to stretch it out over several days. So the recommendation really is about 30 minutes of moderate to vigorous physical activity for 5 days per week. Those are the ideals. It's very difficult to meet for anyone with stroke or not stroke. So in our programs, we make them aware of what those guidelines are. We also identify what their capabilities are and help them to decide, you know, what can you do to be more physically active, because our whole belief is a little more active than before is better.
Any other questions? Yes, go ahead.
Well, one of the things that hasn't really been touched on, although maybe it was alluded to, is motivation. How does someone at home on their own stay motivated and keep going?
For behavior change, and to maintain that behavior change over the long run, absolutely, that's the $1 million question for sure. You have to sustain that motivation. During our 6-month program in the Stroke Coach, a key motivator for people is being held accountable by not their family member or friend, but rather by their lifestyle coach. They've never met them in person. It's all delivered over the telephone, so they develop a good rapport. But they have commonly said in some of our exit interviews that one of the key motivators is, I can't let my coach down, so I have to do what I said I was going to do. People have to have a belief in their ability as well. So it comes down to confidence. They have to know what the outcomes are, I would say, of working hard and continuing to work hard. I think that's a key motivator as well. And if you look into the theoretical literature on self-management and also behavior change, they also say engage social support. So social support in terms of friends, but also peer support. So people who have also gone through similar experiences for you to support that person in the recovery and in the recovery and further.
On that topic, I'll mention the Living with Stroke program, which is for stroke survivors and their caregivers. And we go over quite early in the 8-week sessions physical activity, and we have a physiotherapist usually come in. And you know, it was as simple in one case of encouraging a man to step up on a stool and step down, and step up and step down. And we all congratulated him every week that he came back. And then he started walking around, and that social peer group was very helpful for him.
I just want to add one thing. I think it is very, very important to have perhaps a coach or someone that can lead people through certain activities and help to improve the motivation in that manner. But I do want to exercise one point of caution that as a result of a stroke, an individual may actually lose and this is a neurologically derived issue, that motivation. And so I don't want anyone to leave here thinking that we just need to simply employ somebody to get somebody moving and then they can do that and that they will become motivated, because it's as real a deficit for some as might be the dysfunction that they have on the one side that's physical or the loss of memory. And so it's not sometimes as simple for some individuals to simply have someone give them a little bit of impetus to get going. So do be a little bit careful on that. And under those circumstances, it does become very important to have somebody who can be with that person really on a more constant basis and does serve as that sort of external almost prosthesis to help that person to carry out activities. But the likelihood of necessarily having carryover where that person will automatically become motivated, I think can be a very unrealistic expectation, and then can set you and the person up for failure and really a very negative consequence. So it's important to maybe work with someone to discern why that motivation is lacking first before you decide what intervention might be appropriate.
We've talked about a long-term intervention. Is there any research being conducted currently on immediate intervention, such as, say, stem cell intervention? You've talked about TPA. Is anything on the horizon in that respect?
All that I can say is that there's a considerable amount of research that's certainly being undertaken in terms of that very, very acute phase. But I'm not the right person to comment directly on that type of research, and not sure if...
Andis, can you add anything?
That I think is there are two issues, that there are different types of stroke, and sometimes that could require almost opposite types of treatment. And then the second big challenge is timing. Starting from minute one, there's this crucial window when you can do TPA, and then afterwards you can't overdo TPA, because then you can have also hemorrhagic stroke as a result, right? So I think that is the biggest challenge. So this initial period, which probably there's no single drug ever going to be possible, it's going to be almost an on-hour basis change of strategies which are going to be employed. And plus on that, the brain is 3D. Again, in some places the structure is different, in some places immune response is different, right? So I think this 3D challenge plus time, it gives this 4D environment which needs to be followed to actually design a proper treatment, this acute treatment. And I think that again, are we gonna be there? Yes. How soon? I don't know. It will depend on how much money is thrown at this problem, right? So at the moment, I think stroke is very different to most healthcare, where we wait for people to basically get sick and then try to treatment. Basic research needs to be supported to really go after mechanisms and try to find early drugs which would prevent this disability.
Okay, we have time for one more question.
This
Marie.
is not actually a question.
comment?
It's a comment. There is research being done here in Canada. It's a frontier study. It's the name of the study. We're hoping we might be able to get it going here in Kelowna. And it's a neuroprotective agent that is given in the ambulance as the person is en route to the hospital with their stroke. It's a research study that is currently running in Vancouver, Toronto, and various other parts of Canada.
Great, thank you for that. Obviously some very important research underway on all facets of stroke, right from acute to rehab and primary and secondary prevention. So we're almost at a close, but before we do close, I'm going to ask each of the panelists to share some concluding thoughts based on their perspective or what they've heard tonight. Maybe a few takeaway messages for us all. So we'll start with Jennifer, if you're okay. And we can, it doesn't have to be in a row, whoever's ready.
Well, I was a driven and determined person before my stroke, and I maintained that after. But to all stroke survivors, I would say don't get discouraged because every recovery is different. And although recovery might slow down, it can continue for years. So keep exercising and keep moving and participate in activities like the Living with Stroke group. Thanks.
I would say, and this goes, this continues our discussion on the resources and it then developing preventive services out into the community. I can assure you that it is definitely an area of concern, not only from the group that I work with, but across Canada. There's actually quite a bit of research going into chronic disease management, specifically for people with stroke. And so programs are coming. They're being evaluated, and hopefully sooner than later we'll definitely start seeing more programs available to people who've had a stroke out in the community to stop secondary strokes from happening.
Thank you.
You know, I think, I guess all of you are here because you are actively interested in this, and you are probably having healthy lifestyles and so forth. I would just say, spread the word and information, right? You are here, but next time drag your neighbor who is watching TV at the moment home, right?
Thank you. Thank you very much.
I would certainly echo that, and it really, I think, comes down the row here. But the one thing I would say is that given the challenges from a rehabilitative standpoint, some of the issues that are there and will be there for the foreseeable future, I think all of us would do well to look at prevention, to look at ways that we can be healthier. Exercise, as we know, and any conference that we attend, exercise is always put out as something that has proven efficacy in terms of brain health. And I would argue too that if ultimately you are going to have a stroke, the better shape that you're in, the healthier that you are, the better that you will withstand the effects of that stroke, and the better you will come out of it at the end. So I would certainly argue that, if nothing else, exercise.
Great, thank you very much.
I guess my takeaway from my very narrow contribution to this discussion is don't neglect, essentially. So eye tracking is showing promise. It matters what type of neglect that you have in terms of your functional outcomes. And it looks like we may be able to move towards treatment with that cool sort of eye tracking technology. So stay tuned, we're working on it. Hopefully we'll have some better news soon. So Thank you all so much for coming.
Thank you. Yes, I think you would agree we had a fabulous panel tonight, so would you join me in thanking them all? And I'd like to thank everyone for coming out on such a lovely spring evening. We realized that it wasn't ideal, and so we really appreciate you coming out and joining us. And I encourage you to check out our other Embrace Aging events during the month of March. You might find something else that you're interested in. If you didn't pick up one of these pamphlets on the way in, you can pick one up on the way out, which outlines all of the events. And I would encourage you to fill out the evaluation forms as well, because we'd love to keep doing these cafes. And so if there's other topics or other suggestions you have for us for any kind of event, really, we'd be happy to hear about it. So I'd like to thank again our sponsors, UBC, Interior Savings and Interior Health, for helping us host this event tonight. And I wish you all a safe journey home. Thank you very much.